Okay, good afternoon. We're going to go ahead and start and keep ourselves on time as folks hopefully continue to trickle into the audience. So welcome. This is our fourth of 5 sessions on faculty development and medical education. We have, as a reminder, we really started this to try to inspire a cohort of educators and build as an area for collaboration among disciplines and among physicians and educators in multiple countries. We have an exciting day planned today, which we are going to spend most of the day or the entire day looking at curriculum design and ways that we can intentionally plan the learning experience for all of our trainees and learners. And with that, I'm going to hand this over to our team to get things started and let them introduce themselves.
Okay, yeah, my name is Roderick Lassen-Reindorf. I'm a senior lecturer in Department of Obstetrics Gynecology, and I also have a background, MSc in biomedical education. Thank you.
Hello, everyone. My name is Karen Stahlberg, and I am in the Department of Obstetrics and Gynecology, as well as Learning Health Sciences here in Ann Arbor, Michigan, at the University of Michigan. And I have a master's in higher education as well, and do a fair amount of teaching both online and also faculty development as educators, sort of in person as well. It's a really a privilege to be here with you all, and thank you for inviting us.
Perfect. And I'm Donna Okole. I am an emergency medicine physician by trade, and I'm currently here at the University of Michigan pursuing a master's in health professions education and a medical education fellowship. So like Dr. Stahlberg and Dr. Lassen-Reindorf, we're so excited to be here today talking about curriculum design approaches. All right, and we have no disclosures. And so to start off our presentation with some objectives, we're going to discuss the landmark curriculum design models. We're going to explore competency-based medical education curriculum. We're going to consider different adjuncts to curriculum design. And we're going to review strategies for successful curriculum implementation. So we're really excited to have some audience participation today in order for you to get the most out of this presentation. So we're going to start off with a couple of questions for the audience, and we'd like you to drop your responses in the chat. I think we've got Laura and Rocky monitoring, and they can kind of share out what you guys think. So our first question is, what methods of curriculum design are you familiar with?
Honestly, the idea that there's more than one is news to me. I'll be the first to say. Having formal methods is not something that I'm very familiar with, so I'm excited to hear more and learn more.
Yeah, there are many different methods, and we're only going to touch on a few today. We're really hoping that they're kind of some of the more high yield methods, but this presentation is really more so a starting point with figuring out how to design a sound curriculum that really suits the needs of your trainees and your learners. Our second question is, how do you define curriculum? Any takers on how you would define what curriculum is?
I think maybe, broadly, you think about it as the roadmap through which you are trying to deliver some sort of material to a group of learners.
Yeah.
I think Dr. Reindorfer said it was a blueprint of the kind of graduates you want to develop.
I like that. So you've got roadmaps, you've got blueprints. I think those are all really great jumping off points. And our last question for the participants are, what challenges have you faced implementing new curriculum in the past?
Also from the audience, the last question was answered as a document that outlines program learning goals, objectives, and strategies to enable learners to achieve the expected outcome.
It's very comprehensive. I like that.
My joke for years has been that it never works and completely as designed on paper. So figuring out what your real world implementation hurdles are and finding ways to overcome them to still achieve your goal.
Kind of snowballing up what you're talking about, Dr. Hobson, any challenges that you faced sounds like a lot of times thinking about curriculum is just what's on paper, but what are the challenges or the barriers that prevent us from taking what's on paper and actually that being the true experience of your learner in real time?
Yeah, getting resources. So are your resources available? Does everyone buy in from Dr. Reindorf? Are your goals in sync with the bigger goals that are out there?
Perfect. It's so good to hear and have all of your participation, because I think this presentation is really going to touch on everything that we've talked about just in this quick discussion with these 3 questions. So a roadmap for today's presentation, we're really going to start with talking about curriculum mapping. We'll take a deep dive into Kern's model for curriculum development. We'll talk about competency-based medical education, some adjunct strategies, and then how to successfully implement your curriculum. And I think in this forum, to this point, we've had some really excellent presentations on how to develop OSCEs, how to give feedback, how to implement simulation. But I think this presentation kind of offers the ability to tie all of those things together so that you have alignment and actually a cohesive curriculum. How do you take what you put on paper for what you want your learners to know, to translating that into what your learners are actually experiencing in real time, and then also looking at the outcomes. Are your learners the competent physicians that you want them to be at the end of your curriculum? So today, the definition that we're going to use and kind of ground our work in is that a curriculum is a planned educational experience. Dr. Ronald Hardin, who is a world-renowned physician and educator, defines curriculum more broadly, that it's a sophisticated blend of educational strategies, course content, learning outcomes, educational experiences, assessment, and the educational environment of the learners that implements the learner's learning style, their personal timetable, and the program of work. So a very broad definition that you really can distill down into a planned educational experience. We can think about it broadly as to what is your medical student doing over the 4 to 6 years that they're in medical school, or you can think about it as a simple lesson. What are they learning today on the wards, on their internal medicine rotation? So we hope that today we're grounding this work in this definition of planned educational experience, and that you can kind of take this and use this information to best suit your needs. If you're overhauling your curriculum for your medical school, we hope that we have something for you. And if you're just changing one aspect of a tiny little rotation, we hope that we have something for you as well.
Donna, there's a fascinating comment in the chat about a curriculum is developed by those who attend workshops and administration people. That kind of sets this up as something very other. What are your thoughts on that?
Yeah,
Or
I think
if you want to defer answers until you go into more content, that's fine as well.
no, I'll start it now, because I think that's a lot of what we were discussing earlier, is that there's a lack of alignment between what we're putting on paper and what our learners are actually experiencing. So I think if we define curriculum as something that administrators are coming up with, and it's just kind of a piece of paper with some objectives that we have to turn in for accreditation standards, there's a mismatch between what our learners are actually doing in real time. And the consequence of that is that sometimes we get learners or trainees who aren't competent in the ways that we know that they should be. And so I think really focusing on why curriculum is important and kind of expanding our definition and really grounding it in the fact that we need to know what our learners are experiencing so that we can figure out what and anticipate what those outcomes will be, is kind of the whole point of this presentation. So I hope to kind of debunk that theory that it's just something that we're putting on paper.
Yeah, Donna, just to add to what you shared with a question, I guess the person is coming from the point where you are a faculty and one day you are just informed there's a new curriculum or there's a change. So this is it and work with it. So, and that brings the issue about the different constituencies that must come together and create a curriculum. If it's not broad-based enough, then you finish and very few people know it. and the rest are made to look like they are just implementers. And even if they attempt to implement, the spirit of the curriculum that should be in them and drive, so that when you wake up every morning, what is the picture you have of what you are doing? It's not there. I guess that is the feeling of the question, or part of the feeling of the question, that some people go for workshops, meetings, they go and sit down and they come up with a very nice drawing design. Okay, carry it out. I'm not involved. I'm just an implementer. Thank you.
Yeah. I think that also brings up kind of taking stock of who your stakeholders are. So the curriculum can't simply be designed by administration or faculty. I think it takes really involvement for the student to have an idea of the student or the trainee or the learner to have an idea of what's actually happening and how are they actually experiencing it. And just making sure that you have a well-rounded group of stakeholders as you're going through curriculum design and development to make sure that it's really suiting the needs and achieving the outcomes that you want it to achieve. So we'll start today by talking about curriculum mapping. And curriculum mapping is consideration of when, how, and what is taught, as well as the assessment measures utilized to explain achievement of expected learning outcomes. And so your curriculum map is really a systematic process to document and visualize the student learning experience at a higher level. It also gives you the ability to identify gaps and redundancies in your curriculum, and it affords you the opportunity to make sure that you're aligning your programs with the learning outcomes of that particular lesson, but more broadly, the learning outcomes of the institution. Curriculum mapping can serve as like a foundational process to the understanding of the story that the student is experiencing at your institution. And like we've already said, it allows you to anticipate your student outcomes and really serves as the glue for your curriculum. When you're thinking about mapping, it really shouldn't be a gamble or a surprise as to what your student outcomes are. The map allows you to connect your learning experiences to specific student experiences, and it should kind of serve as work in a cyclical fashion, that your experiences feed into your outcomes feed into your experiences. Your mapping process should take you through this cycle where you're starting with identifying your student outcomes or your learning outcomes. From there, you really want to select and design your educational strategies and design measures. From there, you can plan for data collection and implement your educational strategies and measures. You want to analyze your data, and then you want to use the results to inform your program. And this is the most crucial step. If you're not looking at the data to figure out what it's actually telling you and using that to inform kind of how you're going to go through the cycle and the process again, you're not really getting the most out of the process that you need to. So specifically when we're looking at learning outcomes, we need to kind of think about them in building blocks. We want to look at the learning outcomes from the lesson, the outcomes for the unit, the outcomes for the course, the outcomes for our academic program, and the outcomes for our institution. And the design phase with curriculum mapping really starts backwards. We really need to think about the outcomes for the institution and then get more granular from there. But when we're actually in front of our learners or our trainees, we want to deliver that content forward. Our lessons should build out into units, should build out into different courses, which creates our academic program, which feeds into the overall outcomes of the institution. And so when we're actually doing that, some of the framework and some of the understanding that we need to have is of Bloom's taxonomy. When we're actually going to put our curriculum into a map and put it onto paper, what it actually looks like should take into consideration kind of our novice learners who are at the bottom of this triangle. These are learners who are remembering and understanding. They're simply being given information and expected to recall facts and basic concepts or be able to explain those things. And as we move up in this triangle, our learner is becoming more advanced. They're applying and analyzing that knowledge and drawing connections and creating new ideas. And then as we get towards the top of the triangle, our learners are the most advanced and they're able to evaluate information and kind of create their own individual work. And so when we look at our individual lessons and our individual courses, you need a simple framework to kind of code all of these things. The example that I have today is IRE, I for where you're introducing information, and this kind of correlates to the bottom of this triangle where an introduction of information you're expecting your learner to remember and understand. R is for reinforce, where you're expecting the learner to apply and to analyze. And E is to emphasize, where you're expecting the learner to evaluate and to create. So when you're actually putting this map together, you can have all of your courses kind of listed, and you want to understand what course, or you want to kind of code your courses so that you understand what outcomes are mapped to each individual course. So in your quote unquote 101 course or introductory course, you're expecting to introduce the information to the learners. And as they go deeper into the curricular and take a deeper dive into the coursework, you're expecting them to move up in Bloom's triangle. So you're reinforcing information and you're emphasizing it. So I think a really neat real world example is looking at the curriculum map for the medical school here at the University of Michigan. And this is what the map looks like for all 4 years of medical school. It's broken down into 3 main components that they call trunks and branches. You have the scientific trunk, the clinical trunk, and the branches, which are denoted here at the top. And then you'll notice here that there are courses that are threaded throughout and taken by the students asynchronously throughout all 4 years, whether that be the chief concern course, their doctoring course, improving healthcare systems, or their capstone course. But we're going to look specifically here at this scientific trunk. And what that actually breaks down to is about a year's worth of coursework from August to July, and it's built out into 6 different units called Foundations and Vital Functions. And again, you can see at the bottom, there are asynchronous courses that they're taking alongside these. But if we look specifically at Vital Functions 2, which is on nutrition, absorption, regulation, and reproduction, we can see that the university has built out an example of a week that students are going to experience in that course. So you can see that they're having didactic sessions and actual lectures, that they're participating in different laboratories, whether that's the anatomy lab or the pathology lab. You can see that students are engaging in small groups. You can see that they're also doing their asynchronous learning with their doctoring courses. And then you can also see that they're being assessed at the end of the week to understand what they're learning. And so a curriculum map really allows you to know step by step and day by day what your students are experiencing as they're going through your curriculum. With each of these activities and each of these steps, you can determine what information is being introduced to the students. You can figure out where information is being reinforced to the students, and then you can also determine where it's being emphasized for the students, that IRE framework that we talked about. And so it's important, though, to realize that this is just one simple week as part of one unit, but it all fits in and feeds back into the bigger concept map or the curriculum map that the university has set out. And so that's 1 week in the first year within medical school, but we also have to realize that students are going to have touch points with GI and their clinical trunk. And that's really where a lot of that reinforcement is going to take place. And as they move into the branches, so you have a student who's particularly interested in GI, they might do an advanced clinical rotation in GI, and that's where they're going to be moving even further up into Bloom's triangle and emphasizing that information. So that's just kind of a very broad overview of what a curriculum map is, why it's important, and kind of how to build one out. So our key points here is that learning outcomes need to be linked to your student experiences. It's important that you plan backwards. You want to represent how each aspect of the curriculum is related to one another through your curriculum map, and that your data informs your effectiveness. It's okay. Your map can be very simple and rudimentary, or it can be extremely detailed. And just know that it's okay to start small. You don't need to think about your entire curriculum in the 4 years of medical school and start building out a map. You can start with one course and build out a map for that, and then move on to the next course and then figure out how they're all interrelated to one another. Any questions on that? Okay,
Nothing in the chat currently, Donna.
great. All right, we're gonna move on. We're gonna talk about Kern's model for curriculum development. So this model was developed by Dr. David Kern in 1998, and it's the 6-step approach that provides provides a practical and theoretically sound approach to developing, implementing, evaluating, and continually improving educational experiences within medicine. And so I want to bring your attention to the model that's on the screen. There are 6 individual steps, but none of them are labeled, just because this is meant to be a dynamic model. And I also want to bring your attention to the fact that all of the arrows in this model are bidirectional. So you're not going through this process in a stepwise fashion, but understanding that all of these things kind of work simultaneously with one another and should be able to inform different aspects of your curriculum. So step 1 is problem identification and creating a general needs assessment. So here, you really want to pinpoint a health problem or a learning problem. You want to ask yourself, who does this problem affect? Is it your patients, your learners, your medical educators? You want to determine, what does the problem actually affect? Is it affecting clinical outcomes, educational effectiveness, educational outcomes? You want to determine how big is the problem? What priority does your institution place on actually addressing this? And then what are the current status, or what's the current status of addressing the problem at the institution at that time? And what's being done about it? You want to think about if there have been previous institutions to address, previous efforts to address this problem, and how effective were those interventions? Step 1 asks you to create an analysis of the current approach to the problem. And it asks you to identify the ideal approach to addressing that problem. And the difference between the two is your general needs assessment. So this is really just taking stock of whatever you have identified as an issue and kind of getting a broad sense as to why it's an issue and how you think you might want to move forward. Step 2 is a targeted needs assessment. So here, you're assessing the needs of one's targeted group of learners. You want to assess also the needs of your institution and your learning environment. And the difference between step 1 and 2 is in the specificity. Knowing that there's a problem in your curriculum isn't enough. You really need to take stock of the circumstances around what the problem actually is, and being very specific about who it's affecting. This targeted needs assessment allows for changes in your curriculum to be implemented on without overhauling your curriculum as a whole. Step 3, we want to think about our goals and objectives. Here, you want to start very broad and very generally, and then you want to move into specific and measurable objectives. So your objectives can be knowledge, attitudes, or skills or behaviors that you want your learner to demonstrate at the end of your curriculum. And then your goals and objectives determine the content and the learning methods of your curriculum. They also help focus the learner and provide a basis for evaluation. Really here, your goals and objectives are meant to communicate to others what your curriculum is about. It's important that if you're in a resource-limited setting, prioritization of your goals and objectives really helps facilitate the rational allocation of your resources. So being really specific about what it is that your learners need to be able to do and how you're going to be able to address that with your curriculum. Step 4 is implementation of your educational strategies. So here's where you're going to choose the content that you're going to teach and choose the educational methods that you're going to use to teach them. And with step 4, the goal is to achieve the objectives that you set in step 3. So we've been talking a little bit about alignment today, and I think this is where those two things come together. The objectives and what you want your learner to be able to do really needs to align with how you're choosing to teach that content. So I think a lot of times maybe we want to develop an OSCE or we want to develop a simulation because it's interactive and more engaging for the learner. But we need to take stock that if those methods don't necessarily help us reach the objectives and the goals, that we need to choose a different educational method. And when we're doing this, it's important to start backwards, like we talked about in curriculum mapping. So starting with the goals and objectives and then figuring out how we're actually going to achieve that. Step 5 is implementation. And here, it's implementation of both the educational intervention and its evaluation. So this step requires several different components. You need political support from leadership in your department or your institution. You need to identify and start procuring your resources. You need to identify and address the barriers that might accompany implementation of your curriculum. It's a good idea to pilot your curriculum to a friendlier audience or people who you've identified as key stakeholders before you're actually introducing it to your intended target audience. And then it's also important to start refining the curriculum over successive cycles. So the implementation step is the most critical step to a successful curriculum. You're taking curriculum design and development from a mental exercise and making it actual reality. And then step 6, evaluation and feedback. Here, we're assessing the performance of the actual individual learner or trainee, but we're also assessing the performance of the curriculum through like a true program evaluation. And again, I think we've already had a session on feedback and evaluation, but we're using both formative and summative assessment. Formative assessment being for learning. It identifies areas for improvement, while summative assessment is kind of your final evaluation or assessment of learning. It's that kind of final grade or verification of achievement. Evaluation needs to be used to drive the ongoing learning of the participants, which is kind of the formative assessment. But your evaluation can also serve to garner support and resources for your curriculum. So if you're showing improvement in a specific area, that might allow you to gain more stakeholders or gain more political, I don't want to say power, but advantage to drive your curriculum forward. So back to kind of what the model looks like when you kind of put it all together. Like we talked about in the beginning, not all of this stuff needs to occur in sequence or in a step-by-step order. It's a dynamic and an interactive process. So you can be working on one step at a time, or you can be working on multiple steps at different times. But again, bringing your attention to the fact that all of these arrows are bidirectional. So you could be looking at educational strategies, and while you're doing that, you're also refining your goals and objectives, because like how you're implementing your program could change. You could be looking at your evaluation and your feedback, and it also allows you to identify different problems that you didn't address the first time. And so you can go through the process again. So just know that as your curriculum is evolving, that evolution is what is making your curriculum successful. So I wanted to provide you guys with an example of a curriculum that I designed myself while I was in residency. It was a trauma-informed care curriculum. And the point of this was to kind of use the Kearns framework and the Kearns model to address a problem that I realized in my residency. I trained in a city that had high volumes of blunt and penetrating trauma, and I realized that there were increased amounts of stress and burnout among amongst our residents. And so that's the problem identification step. As I went through a general needs assessment, I had to understand the barriers that led to that increased stress and that increased amount of burnout. We worked a difficult call schedule. There was a lack of sleep. There was inability to kind of flex the rotation schedule around. So it was just hard. But as I went through a more targeted needs assessment, I realized that there was a lack of time or space or skills to actually debrief some of the difficult cases that we were seeing in residency. And so part of the goals and objectives for this curriculum were to include formal training on trauma-informed care, specifically how it relates to healthcare providers, but then also introducing best practices around debriefing. For educational strategies, we implemented lectures and interactive simulation sessions so that residents could practice these skills and the goals and objectives. And then evaluation. We surveyed the residents before and after the curriculum and were able to measure improvement and show that we had met our goals and objectives. So I think Kern's model is this 6-step process, but it doesn't need to be something that you only employ for a curriculum as a whole. It could be one short little session that you're having with residents or your trainees or your learners, or it's something that you could actually implement for your curriculum as a whole. So you can think about it multiple different ways.
Donna, you talked a little bit about the importance of evaluation and reassessment, and that gets at my joke about it never works as designed on paper. What sort of refinements did you find that you had to make after the initial iteration of this curriculum based on the feedback you received through your evaluation process?
Yeah, I think specifically for this curriculum, the simulation sessions that we use to teach residents for debriefing, I think what was great is that we used real life cases. The residents came up with the cases and told us kind of what they had experienced and what they wanted to debrief on. But I think that reiteration of this curriculum looks like giving the residents a formal tool. We kind of went through best practices of debriefing kind of in general and what it looks like for the chaplains and the spiritual care team at our hospital and how they kind of lead debriefing sessions. But looking at the literature, there are actual tools and frameworks that you can use for debriefing. So for me, for this project, reiteration looks like giving someone like a little card that they can put on their badge that goes through specific steps that they can use to debrief, just so that it could be a little bit more effective and not like this nebulous idea that residents had to think about. I don't know if that answers your question.
Thank you. I think that's a tremendous example.
Yeah. Cool. So we have an exercise for the audience, and we'll give you guys a couple of minutes to kind of go through this, but I want you to pick any one step of Kern's model and then determine how you would use it to apply to your curriculum as it stands right now. So I think some people might come up with a problem or identify a problem that they're having in their curriculum right now. If you want to throw that in the chat so that we can kind of share out, that would be helpful. Maybe you've just gone through a curriculum review and you have some data that you're looking at. You want to share out kind of what that data looks like and how you're going to use it and apply it to a reevaluation or a redesign of your curriculum, that would be helpful. If we've got no takers, that's okay. But just to kind of round out this discussion of Kern's, just remember that it's a 6-step framework for curriculum development. It's dynamic and it's non-linear. And just remember that making progress in one step oftentimes influences the progress that you're going to make in other steps of your curriculum. And for a successful curriculum, the development never really ends. It's simply evolving as you're getting more data and information and results. It's also evolving as you have a change in your resources, a change in your targeted learners, or changes in your material that's required for mastery. Any questions on Kern's?
Donna, this is a great overview. And I think one additional example, which we might share with the group, I'm working with a group of medical students currently who are interested in the pre-hospital environment and how do they get exposure to the medicine that happens outside the walls of the hospital. And one of the things we ended up spending a lot of time on was not only sort of the needs, but how do we map those needs onto the needs of the medical school, learner needs as well as medical school goals, and also how do we deal particularly with the implementation phase where safety of the learner is a very different consideration than in the general hospital. And I think I saw Rocky Otang with a hand up as well.
Yes, Donna, I did. I had my hand up because if you can go back 2 slides to your Kern's 6-step process there. You know, what I was going to say is that in the Faculty of Emergency Medicine at the Ghana College, this is kind of we're at the needs assessment phase. We've actually built out a needs assessment to go out to our residents to sort of get a sense of what their thoughts are about the match between what is on their curriculum and what they are learning clinically as they go through the residency. So we've had a couple of residents actually and a couple of attendings have helped us English build out a survey meant to go to the trainees as well as the trainers. And we actually have piloted it and are now at the point of trying to get IRB approval to send it out to other faculty to get a sense of, you know, where they are as it relates to the needs assessment. You know, what is it that they think they need now? They've been residents, they are in training, and then there are faculty who are providing the training. Where do they see the holes and the gaps in the application or implementation of what's on paper to what they're seeing in the hospital? So I thought I wanted to share that because that's something that we're doing through the college.
Yeah, I think that's an excellent example of how Kearns works in real time, how your needs assessment, you started a pilot program or a pilot survey off of that needs assessment, which really is implementation. And all of that's feeding back into your evaluation and your feedback. And all of that's going to help you better refine your goals and objectives and lead to different educational strategies. So I think that's a really good example of like how Kearns works in real time and how you take that framework and actually implement it and do something with it.
And one of our participants is noted that they're working towards evaluating the Palliative Medicine Fellowship and the Modular Family Medicine Program of the Ghana College of the Faculty of Family Medicine. So this is very active work that many of our participants are engaged with.
And I think exactly like you said, Laura, it's active work. And I think now you kind of have some language around the work that you're doing, because I think a lot of this stuff is happening in real time. But you just needed to know to put the Kearns name in the model and the framework and kind of use those pieces to kind of help bolster the work so that it's not just you talking and you sharing random ideas, but it's like rooted in theory. I think that's really important.
And the Kearns has written, and collaborators have written a textbook. It is in at least the 3rd, if not 4th edition. I may buy it in bulk off Amazon, which online, and hand it out. So I have multiple copies in my office. And I think most of it is available if you actually just search Kearns Guide to Curriculum. You can probably find these as free resources on the internet without too much difficulty.
Great. Well, thanks for sharing out. I think this is probably a good breaking point for us for the first half of our presentation.
Okay, for a long session today, we are going to take about a 10-minute break, and I will display my tenuous facility with time zones that everyone has been making fun of me in a friendly way over the course of these sessions. So we will be back in about 10 minutes, which is about 17:05 GMT. So let everyone take a break and we will continue. Okay, team, welcome back. We're going to spend the next hour or so diving back into curriculum design as soon as our team is ready. During this session, I'm also going to drop a link to an evaluation form in the chat. And if everyone could be so kind as to provide our presenters some feedback on their presentation, and that will also help to inform some of the future educational offerings by the Ghana College. So thank you very much. Stage is all yours.
All right, thank you very much. Let me first acknowledge Dr. Coley and Dr. Staalberg for the great input in the slides that are yet to be shown in this session. So thank you very much, Dr. Coley and Dr. Staalberg. We're going to talk on competency-based medical education, and I'm sure it's a term we've heard about. What is it all about? This is a movement to move away from a system where you went through a prescribed course, 4 years or 6 years, if you're in Ghana, and then end of the day, say you finish. But the emphasis is on the outcomes. When you graduate from medical school, what are you able to do? What are the competencies that the entire education has given you? So it draws a clear line between just running through a prescribed course as opposed to you having competencies in predefined outcomes or predefined areas that they want you to go through. The other thing is that because it's competency-based, how do you certify somebody to be competent? You must have been observing certain things to say this is competent or this is not competence. So it requires more observations from the instructors or the trainers to certify that these prescribed outcomes have been achieved before leaving medical school or residency school. And that obviously will lead us to have more frequent assessments to see that or to ascertain whether trainees are where they are supposed to be or they are behind. So the Royal College of England, the Royal College of Medicine and Surgery in Canada, the United States Accreditation Council for Graduate Medical Education, and many bodies have come up with some core competencies that by graduation one should have. And the one I'm most conversant with, the ACGME one, the first one is patient care. By the time you finish medical school, you are expected to be good with patient care, then medical knowledge, then interpersonal and communication skill, then systems-based practice, professionalism. So, and when you look at all these bodies, the CAMMEDs, the GMC of the UK, the body that regulates the practice of medicine in the UK, they all seem to have these core, they may put it in different ways, but essentially they converge in the same competency that I expected. And this competency-based medical education has been pushed to the front burner in the last 20 years because of many injuries and problems that patients suffer. I mean, there may not be statistics for our country, but if you check the literature now, they say about 800,000 patients have a misdiagnosis or some kind of injury in the United States. And that has made educators think about what can we do to make practitioners better and reduce the impacts, these negative impacts on patients. So that drive, has gathered steam, is moving on, and we can talk of CAMMED, you can talk of ACGME in the GMC, And of course, I shouldn't forget the Institute of Medicine of the United States. That also speaks to the same thing. So competency-based and medical education, we will look at three terminologies we have to make our discussion go forward. Competencies, and then what appeared in somewhere 2005, entrustable professional activities, EPAs. By the way, it's not Environmental Protection Agency, it's entrustable professional activities, and then milestones. And when we talk of competency-based medical education, as I've already alluded to, is the outcomes that are the focus. So in the curriculum you design, the focus is on the outcomes. And these outcomes are built on each other. And as Dr. Okoli mentioned earlier on, they are reinforcement. They are organized in such a way that as you move through year 1 to 2 and 3, and the last year, they are reinforced. And then the EPAs, we will get to it, is talking about what can be entrusted to a practitioner without requiring the supervision. So entrustable professional activity is a unit of professional work, and it consists of, there are many competencies in it. I'll give an example that can be entrusted to a learner for unsupervised practice. If there comes a time where you need to supervise a trainee to ensure the right things are done, it means with that the particular unit of professional work, that trainee has not reached a point where he or she can be left alone to practice it. So if we take the example of, okay, you perform a consultation and deliver bad news to a patient. So you're going to break info bad news to a patient. This can be seen as an entrustable professional activity. This activity is within a broad range of things, but if you take this particular one, it requires, one, the person breaking the news to have good medical knowledge of the situation. Number two, he should have good communication skills, showing empathy and all that. And for me to certify a trainee that, okay, he's more than enough to deliver bad news, I must have observed, the training in a clinical situation in particular, for me to say this particular activity has been well done. And competency is in the area of knowledge, skills, and attitudes. And example is taking the history of a patient. You are taking history, but in the background in your mind, you need a lot of knowledge. If a patient complains of coughing and producing bloody sputum, is the knowledge in the background that guides you using your communication skills to collect the relevant information that essentially will come and compose what is a good patient history. And milestones have got to do with developmental steps that mark a progress in competency. And let me say, these things are also hinged in Dreyfus' model of learning to gain competency, where you start from a novice and you move on to advanced beginner, then you move on to competence, and then proficient, and then you become an expert. So when you put all this together, it looks like, where is the point at which you say, I can entrust this professional activity to my trainee? Definitely, you should reach, on the Dreyfus scale, you must reach the competency level before such a training can be left on his or her own. So if we take example, describe the elements in a history taking. Of course, it involves gathering relevant information from a patient, but it also requires actively listening and responding to patient with cues and showing sensitivity and empathy. And these are all, you can trace them to knowledge, patient knowledge, and communication skill. So for every entrustable professional activity you look at, you require probably 2 or more of the 6 competencies that you find in the ACGME, the competencies that are required. So if you can see this slide well, I'm trying to put all of them together. So you are supposed to provide, this is an example in a textbook, Evaluation of Clinical Competence by Eric Humble, Hawkins, and Downing. You're supposed to provide a telephone advice to a patient. So that is an entrustable professional activity we are talking about here. And you may need sufficient medical knowledge to do this well. And then interpersonal and communication skills will also come in. And then professionalism. So you may not require all the 6 competency areas, but 2 or 3 may feature. And where is the trainee on the milestone? Is he just observing this activity being done? Or does he require direct supervision to do this? Or now you can supervise by his indirect, or is it oversight only, or the person has reached a point where no supervision is required? So that is what essentially EPAs are about. And I mean, fortunately, in the ACGME, all the residency programs, they have defined these EPAs for different specialties. And probably we can look at, in our various departments or specialties, look at them and see where we want to adapt them, or if we want to take everything by whole and then build on, because it will be a rational, appropriate way in monitoring our residents in particular. So you start your residency day 1, it should not dawn on us on the 35th month, when you are by a month away to finishing, for us to realize weaknesses and deficiencies in the training. And if we're going to go this route, then we'll be able to identify the weaknesses of our trainees much earlier, give them feedbacks, and correct these weaknesses. So this is what I've already referred to, the American Accreditation Council of Graduate and Medical Education of the United States. So patient care is a competency that irrespective of the specialty is required. Medical knowledge, what some would call the book stuff, then professionalism, systems-based practice. How does your practice relate to other specialty or the entire environment of your community? And then practice-based learning. How do you do reflection and resorting to literature to improve and practice on current evidence, and then interpersonal communication skills. So if you take these competencies, then if you have a specific and trustable professional activities, 2 or so will be required in delivering the EPA. So you see there are 2 images there, some suturing on the left image. The outcome we are looking for here is entrustment of decision making. So a trainer will be observing a trainee, and the trainer will, end of the day, decide, was he able to, of course, not in the presence of the patient and everybody, but in the debriefing session, see what went well, what did not go well, and has he reached a milestone that is sufficient for us to say that we can now entrust this activity to the trainee. And entrustable professional activity, this is a paper by Shorey and Co. That was describing entrustable professional activity. And of course, is gaining momentum in the last 20 years or so. It's gaining a momentum because without definition of milestones, EPAs, it's quite difficult to determine whether the outcomes you set out in the curriculum from the beginning, have been reached. And I must mention that, well, I don't think everything is known about it now. More work is ongoing to make it better, for us to know more on how to deliver more in our training. Entrustable professional activity is not equal to a milestone. So entrustable professional activity, you are referring to essential tasks to be performed by the learner. And the milestones deal with the abilities of the learner. So if I can take, say, cesarean section, it's an essential task that a learner must be able to perform. But the milestone will determine where the learner is in performing this activity. He may be a novice or an advanced beginner, or he may have reached the level of competence where I can feel safe, okay, I can leave this learner on their own to perform cesarean session while I sit in the coffee room or I stand behind and watch. Many times they will be nervous if you are standing nearby. But from novice, advanced, beginner, through competence, then to proficiency, and then of course expert. That refers to the abilities of the learner, and the EPA is actually a specific task that you can say, I can entrust it to a learner because now he's gone to a milestone where he or she can be left alone. So there's a competency level. You may start low and end up at 5 or level 5. So level 1 may be, let's say, a novice, and you move to level 2, advanced beginner, and then level 3 is competence. And you see the arrow there is, as it moves right, then the entrustability is increasing. And at level 4, I think you are looking at proficiency, and entrustability has gone up. And probably at that point, you want to leave, the training can be left alone with safety. And level 5, this is an expert you are talking about. And as you move across, then your knowledge, skills, and attitudes will be building up. So we try to put these concepts into cards. It's not yet done. Cards for our residents to use in Komfo Anokye in Department of Obstetrics Gynecology. It's not Komofo Anokye. There was an O there that shouldn't be there. So if you take antepartum care and complications of pregnancy, where is the resident? So if you go into clinic, you are managing pregnant women and their complications. Where is the level of the resident? Is he just demonstrating a basic knowledge of normal obstetrical care and common complications in pregnancy? Or he's at the level where he provides complete antepartum care for women with uncomplicated pregnancies and recognizes basic risk factors, symptoms, and signs of common medical and obstetrical complications? Or has he reached level 3, where he provides complete care and for women with complicated pregnancies and manages common medical and obstetrical complications? or level 4 or level 5, where he's gone beyond all these and he's able to manage a patients with complex and atypical presentations. And then he's also reached the level where he's able to teach others below him. And I think that if we take all these EPAs, I mean, fortunately, ACMG has done this work already. We can look at them, and if we shade them into cards, then in reviewing of these cards, we should be able to see how our residents are progressing. Are they at level 1 or level 5? And we're currently, as it is now, I don't see my way too clear in terms of a systematic way of identifying the level that they have reached. And we are suggesting that this can be done to help us better monitor and see the progress of our residents. So this is the whole picture. To your right, you have the various competencies there. We can put them there: patient care, medical knowledge, interpersonal communication skills, professionalism, system-based practice. And then we can define the individual EPAs. And when you define the individual EPAs, for each EPA, where has a resident reached? And that is a milestone. You see, at the lowest milestone level, or he is midway, or he is at the end of the milestone. And that is how we can track and be sure that our trainees are graduating with the outcomes that we predetermined at the time we're designing the curriculum, so that we can be sure there is competency in the training. And this calls for regular evaluation. I know in some jurisdictions, either monthly or quarterly, there is a discussion between a trainer and then the trainee. And because there's well-defined program, you know where each trainee should reach at a point in time. So a discussion goes on as to what the trainee has done in the last, since the last review, maybe a month or 3. And if a trainee is lagging, then it will become obvious in the discussion. And remediation can be planned for those who are lagging behind. And this is good in a sense that you will not finish, say, 6 months or a whole year, and what was required for you to be done were not done. And every now and then, we also need to gather information, as Donna talked about, and evaluate the information. Training is going on. We talk to residents, either face-to-face or through surveys, and the information will have to be looked at, and this information then will form, will feed into how do we make the whole program grow and better for the learner. Yeah, so the key points we are talking about here, that if we are looking at competency-based curriculum, then we're going to have some competencies, and these competencies are measurable by both the learner and the trainer or the examiner. And the goal is that we want to entrust specific tasks to trainees who will do them unsupervised. And so many tasks coming together will constitute all the competencies that we want to have in the curriculum. And with this kind of system, a trainer, a learner is able to track his or her own progress and say that, oh, okay, now I'm able to do this. I'm able to do this without supervision, on and on to the end, where all the EPAs will come together and you have a well-educated specialist graduating to serve the public. So I'll pause here and take some questions. And I expect a lot of questions here.
I mean, you're basically announcing a massive initiative similar to what we did in the US in 2012. It was just as I was taking over as running a residency program, and that change in perspective was huge. But once we got used to it, it was so incredibly useful to have these anchored scales that told us what people were really supposed to be doing and performing at their level of training.
Excellent.
And I don't see anything in the chat currently, but I'll keep an eye up and loop them back to you if I see them coming later. And it looks like we'll hand things over to Dr. Stahlberg.
Wonderful. Thank you so much. You know, every time I hear these lectures and discussions, I learn more and more and think about other ways to look at the content. And so I'm very happy to talk to you about sort of what are the ways in which you can teach towards these competencies or towards these milestones. And so we're going to talk a little bit about a variety of pedagogies, if you will, or ways of teaching that can help capture sort of real work-based understanding for your learner and also for the assessment. So I think, yeah, thank you so much. Mind reader over there. So first I want to talk about OSCEs, or observed standardized clinical experiences or exams, depending on if you use them for formative or summative feedback, as well as having standardized patients as well. So the advantage of these standardized patients, so individuals who are trained to portray some sort of chief complaint or illness or disease state or emotions, or you can use any kind of topic in these standardized patients and OSCEs. And what it does is it gives your learner the opportunity to practice patient encounters and learn in a very structured environment. So both the standardized patient as well as the faculty member can provide coaching and observe the behaviors that the learner engages in, and then give feedback to the learner. These are very useful for unique or less common clinical scenarios that can be created so that learners can practice situations that they may not see often or may be very stressful or difficult. So things like giving bad news or delivering a difficult diagnosis. I wanted to pause because I actually have the chat up just a little bit, and I think we might have missed a question. Dr. Hobson, do you think we should go back to competency-based, or should we wait and catch it at the end?
Let's catch it at the end so we can do our due diligence to this important question as well as the topic you're on right now.
Fantastic. I just didn't want someone to miss out. So thank you for that guidance. So we can go on to the next slide then. So you can think of OSCEs or those types of teaching opportunities much like a simulation, because you're simulating a patient interaction. You're actually simulating a patient who has a script and a way to act and a way to even portray neurologic differences or different types of physical exam findings. So I used to help train the standardized patients to portray abdominal pain, where they would learn to tighten their muscles so that they could mimic sort of a rigid abdomen kind of thing. But many people think about simulation as sort of these very high tech and advanced technologies. But the truth is that you don't have to have necessarily the highest form of excuse me, fidelity. So it is very easy and very, sort of appropriate to learn first how to suture using the skin of a banana peel. It's nice because there's actually two different layers, right? There's that sort of whiter pith, and then you can sew the skin together. There are also simulations that are only parts of people that then can actually be attached to another person. So for instance, if I were going to teach somebody how to do blood draw or blood infusion, they could learn how to place the IV and place the blood, but that arm could be attached to me and I could portray things as a patient, sort of how to interact, pretend that it's hurting. And then of course, we all know that there are these high cost and high ability mannequins that can simulate all sorts of things. But the other thing that's really important to recognize is that there's this sort of continuum of these opportunities, and really highly trained learners or highly experienced learners may not find the banana example as valid. And so sometimes that face validity of like, hey, I really need to be in a true simulation because I'm a high performing team and we need it to look real, right? But I will say that for novice learners or learners who are getting ready to think about doing these procedures, right? The banana works well. In obstetrics and gynecology, we actually have used round melons or watermelons and have put different types of like fabrics on it to simulate teaching a cesarean section. We've also used papayas, very ripe papayas, to help people learn how to do endometrial biopsies or to place a hysteroscope. And that really is a good entryway to the simulation. You don't necessarily need all of these like high-tech things to actually teach very important skills. Next slide. Thank you. So best practices for simulation really include deliberate practice so that people are intentionally structured in the way that they're learning things. We want to make sure that people get skill acquisition as well as maintenance. So you may learn something as a first-year resident, but because you haven't done it in a while, it may be important to go back to the simulation lab to do the procedure before you actually do it in the real world. We also can use simulation for high stakes testing. So a number of our board examinees here in the United States actually do take simulated sessions to sort of say, yes, you can move forward because you can do a clinical simulation and speak to a patient and perform these tasks. The other thing that's really nice about simulation is that individuals can really get into the mastery of things. And they can also get very good feedback, whether that's from the patient who's portraying the case, or the device, if you will. Many of them have ways to sort of say, you did this, or you didn't, your chest compressions weren't strong enough. Their teammates who are in on a team simulation can provide feedback. So there's lots of ways that simulation can be used to provide a safe environment for learning that can allow for duplication and replication, as well as ensuring that somebody knows how to do a procedure or some sort of task before having them do it in the clinic on real patients. So other sort of high tech or well distributed ways to teach or deliver curriculum include this notion of massive open online courses. So one of the sort of earliest ones, and people are very familiar with, are Coursera or edX, or in Europe, it's FutureLearn. But basically, they're large learning platforms that allow for thousands of individuals to be enrolled at the same time. And you can share information as well as getting this incredible reach. The other thing that's really interesting is there are also all of these collaborative and online resources with collaborative learning models like Pathoma, which is something our students use for pathology. Sketchy focuses on microbiology and pharmacology. Online MedEd actually got its start within the clinical years, helping students master the wards on their rotations. Boards and Beyond actually focuses on preclinical information, so typical, first and second year type of information in undergraduate medical education. What's very nice is that you can also use like social media and other free and open access medical education sources. Emergency medicine and critical care has really led the way in these open spaces. So I'm not sure how many of you have had the opportunity to listen to the podcast or look at the open online resources. In a survey of, we can keep going. Thank you so much. Sorry. No, you can go forward. Sorry. Other options include Radiopedia for radiology interpretation, Life in the Fast Lane to help with EKG interpretation. So the other nice thing is that with these free and open access medical education resources, you can, when you blueprint, right, go and look for ways to teach the information. You don't necessarily have to be the one to build it yourself. So Ortho Bullets is another example that has sort of all of these options for videos and treatments and differing ways to get didactics and small groups and problem-based learning. And if you look at the numbers of sort of all of the people who have engaged in these spaces, it's heartening to see that a lot of our learners are out there on the internet finding their own information. It's also really heartening to see that, boy, there's this curriculum that exists out there that has been sort of vetted, if you will, by thousands of people. And so by inference, you can say, well, this is a good resource that we can utilize in our own program. Other things that there are so many resources out in the MOOC domain where people can learn computer programming. There are artificial intelligence free things out there now. There's ways to look at anatomy and teach anatomy. And so what we were wondering is if any of your learners are using MOOCs or foamed, or have you used them all in your curriculum? And so and we were hoping you could put that in the chat. Oh, Dr. Oteng, you put something in there as well.
I think that one connects to the prior question that we're going to drop back to.
Got it. Thanks so much. So wondering if anybody in the audience has some open resources or other online learning objects that they're using in their curriculum.
So I'd second your comment
I do
about
not
ortho
know any official one. I'm sorry. I don't know of an official one. We have up to date in our school, but apart from that, I know individuals use other ones. There is a participant, Dr. Norman, probably she told me about 2 of these online resources that are very good. Dr. Norman. Yeah, but my school has up to date, and that is accessible to all students, faculty to help.
Yeah,
with-
that's wonderful. Up to date is a great resource because it has not only the basic science and the pathophysiology, it also has recommendations for treatment and handouts that you can give to patients. Sometimes the institution has to have a paid subscription to Up to Date. I see in the comments that people have used Coursera before. Some of the residents are using Radiopedia. It never ceases to amaze me how individuals can find online resources. OrthoBullets is a good one. WeChem, Lecturio, Osmosis. Yeah, I'd be remiss if we didn't mention Osmosis, Amboss.
Okay.
Yeah, there's so many out there.
Yeah.
Journal
I
feed.
think the one I was referring to by Dr. Norman, yeah, he just put it up there. We use Lecturio, Osmosis, and Amboss.
Mhm.
Thank you, Dr. Norman.
Yeah. Yeah, no, that's wonderful. And then the other things is a lot of people share their own sort of things they've made in OneNote if you're a Microsoft system, or they share their own flashcards with one another. There's just so many things out there. So the key points really for this section were about ways that learners can practice mastery, but also for us as faculty to be aware of the resources that our learners are already using, because they have sort of vetted them and found them useful. And so if you can find a way to incorporate things that they're already using into your curricular change or adjustment, then number one, it may be a cost saver. And number two, it's already something that they're used to using, and you may have sort of better uptake and better engagement from your learners. So wanted to check in and see if there were any questions or thoughts about this before we move forward to thinking about, okay, how are we going to make change?
So Dr. Stahlberg, we're seeing a bunch of resources, adjunct resources that are out there that we all know are tremendous. Emergency medicine sort of was one of the early adopters of these FOAMed resources of free open access medical education. One of the challenges we've seen is a bunch of them now either are heavily embedded with advertisements or behind paywalls and requiring subscriptions, which it makes sense from a business model. Any thoughts about how people can navigate that increasing cost that's now associated with some of these really valuable resources?
Yeah. So there still remains a lot of open access. And I would say that our informationists, folks known as librarians, actually really have a good line of sight on where those free resources live. There are places like JSTOR, STOR, where you can find things. A lot of them are very dependent on internet access. And so sometimes, you know, I don't know about you all, we've had some weather issues around here that have interrupted services. Quick question that I just noticed about assessing competencies when you use MOOCs. So one way to think about MOOCs is that they're like glorified textbooks and experiences. Though MOOCs generally are developed with hopefully sound educational principles. And so one thing you could do is review the MOOC yourself to say, okay, here's the foundational material. And if you pass with X percentage, and you can show me the certificate at the end, that counts as sort of a baseline of what we're going to expect you to know before we move forward in this next component of the curriculum. One of the challenges for MOOCs, especially on Coursera, although many of our colleagues are figuring out ways around it, is that a lot of it is very cognitive based. And so trying to do skill training or evidence of skill training requires a little bit of sort of instructional design finesse, if you will. But one of, and I don't mean to do like a shameless plug, but the University of Michigan Online has a number of Coursera courses that are across our educational domains. So music, theater. So the reason why I bring those up is because they have unique ways of teaching that may transfer to a med ed space, depending on what you want. Crazy Notion might be that I know there's a MOOC about stage makeup. And so, boy, what if you could like learn how to do stage makeup and put it into a simulation for mass casualty or something like that. Interesting, creative ways. I think that the opportunities are endless. Like the only thing is just how you can consider using them.
I think something that I would like to add is that, MOOCs and FOAMed are not meant to replace traditional education strategies and teaching. So I think it's important to understand what resources your learners are using outside of their traditional didactics and lectures, just to have awareness of where they're getting their information from. But it also should drive you as an educator to kind of have a deeper understanding as to why are your learners requiring these extra resources? How is the information being taught in these resources that connects with the learner so that they're able to retain the information and apply it versus the traditional education strategies? So I think if you're recognizing that your learners are leaning on these other tools, using that as kind of feedback as to what changes can you make in your curriculum so that the information that you're providing them is also useful.
Yeah, no, that's such a great point. And, it's much like when you're trying to do a research project and you look in the literature to see how other people have designed their methodology or their studies to kind of understand their outcomes. I think this is another way to get ideas about how to teach, to see how people are teaching that learners can relate to and understand. And sometimes you may pick up gaps or things that like, boy, I wish we had thought about that as well.
I think there's really also an opportunity to utilize these creatively in a way that may not require you to generate your own content, but can be adjunctive. So for our procedural competency for interns, we completely outsource the knowledge acquisition component and said on your own time, you can review videos, you can work to pass these sort of multiple choice tests that say you have the knowledge, and then you're going to be ready when you come into the sim lab to practice and ultimately go through a competency assessment by the end of the day. And it actually sped up the amount of in-person time that we needed by leaning into some of these pre-existing resources.
Yeah. And the way I think about it is curation, right? Much like you would select a textbook, you might look at these resources and select what to do. As part of our simulation center, we actually opened an iSim. It's a 24-hour place and space where learners can go and, perform laparoscopic cholecystectomies or do more training on box trainers or suturing so that they can feel more prepared and they can access that training on their own as well. So that kind of gets us to the implementation strategies of like, okay, I've got all of these ideas. We have all of these new thoughts about how to scaffold learners. Like I'm seeing some conversation in the chat around meeting learners where they are at their level, at their appropriate milestone, thinking about what is it they need to do. And so that gets into these implementation strategies, where the first thing to think about is like, where are our learners learning things, right? What locations? A lot of times we've got them in the books, we've got them in lecture halls, we've got them in clinics, we've got them in the operating room. And so sort of matching the pedagogy to the environment. So, you know, if the plan is to be able to have people come to the operating room, then making sure that they go to the simulation center to learn about how to suture before they come in and you ask them to, you know, close the incision. If you're going to have them in the clinics, then make sure that you're sort of showing them and teaching them what does it mean to find the chart, find the room, talk to the patient, how are we documenting? We have the luxury of a lot of online textbooks that our learners don't even really know about. They live in our library and they can access them, but I've found that a number of our clinical students don't even know that they can access them. So really designing backwards from like, what do you want students to be able to know, you're good, to know, do, or show, and then thinking about where is that coming from, where is that content, how are we going to make that happen? So it's really important in your design phase to make sure that you've got stakeholders in the process. That includes leadership, faculty, the staff, standardized patients, learners. Really consider what you want the learner to be able to do and start with the end in mind. Make sure that you've got assessments so that you can think about, okay, how do I know that they know, right? And make sure that assessment plans are realistic. So you may or may not want to do multiple choice questions to prove that somebody knows how to suture, right? You may actually want them to be able to show that they can suture and that whatever they put together kind of holds water, if you will, right? Other ways of thinking about, like, we're going to design this new curriculum, but we need to really figure out if it's effective and how it's working. And building those assessments ahead of time is also really important. So is it OSCEs? Is it oral exams? Is it 360 evaluations, asking patients after their experience, how did things work? Talking with other staff in the emergency room to say, when I'm working with this learner, I can rely on these things, or I can trust them to be in this place and space. The other thing that's really important is running pilots. So to not try to, as I tell the many of my students, don't try to boil the ocean. Start with a little bit of engaging faculty, using a curricular map, evaluating design and curriculum. I think that I was not judging our time very well, and I apologize for that. And so I want to make sure that we close with engagement from all of you. And so of the strategies that we've discussed today, what do you think you could implement at your program or institution? What has stuck forward with you? I'm going to hand it back to Dr. Okoli so that she can close us out.
Yeah, perfect. Thank you, Dr. Sahlberg. So if you have any strategies from any part of the lecture today, please drop that in the chat, because we really do hope that you take something away from this discussion today. And while you're typing, I'll go over some key points just from the implementation and design phase. So just remembering that you need to invest all of your stakeholders. Again, it's not just the administration who hands you a curriculum and you need to implement it, but it's thinking about who is actually doing the work, who are the learners, who are the trainees, who are the patients, who are the standardized patients, who are the faculty who are really implementing that. And then mindful planning. We've said multiple times today, planning backwards and knowing what you want your outcomes to be and using that as your starting point for coming up with curriculum. And then targeted assessment. This work is almost meaningless if you have no data to back up what you're doing and why you're doing it, and how you're using that assessment and how you're using that data and evaluation to drive your curriculum forward.
I
So-
see Dr. Betty Norman's hand up.
Yes.
Oh, sorry, there's a last slide.
Oh, yeah, I'll just quickly go through this, but just know that it's okay to start small. The expectation is not that you take your curriculum for your medical school and throw it out the window and start all over again. Curriculum design does not always have to be de novo. It can start with just simple revisions for what you have in place right now. There's multiple different methods of design that we talked about today. Sometimes your design could just start with looking at creating a curriculum map for 1 year of your medical school or 1 year of your interns, and figuring out how that fits into the rest of their education. I think the big thing that we want you to take away today, though, is that the emphasis should be based on student outcomes and their abilities, and tracking that data so that you know where your learners and your trainees are in their education. And then again, start backwards, knowing what you want the outcomes to be and assess that work.
There are a couple of questions in the chat that I'd like to throw to our presenters. One is, I guess implementing competency-based training requires us to map the competencies and EPAs from undergraduate to fellowship levels. So really across the spectrum of medical training, because certain assumptions have to be made about the entry-level competencies the learner has achieved. Am I right?
Yes, so Beryl is right, not for us to assume certain things, because people train in different places, and during housemanship, some basic skills may have been missed. And when people start a residency, I think is not safe. Let me give an example where you have a new resident, first month a residency. There's a woman with 3 previous cesarean sessions, and this guy was asked to do the cesarean session, and let's say it's unsupervised. The consultant is not there in theater to see what is going on. And you may find some people doing residency who don't have the skill. They may have done a few cesarean sessions, but for a 3 previous cesarean session that may have adhesions, it may be way above their skill level, and you endanger the life of the woman, and you end up putting the resident in trouble. So it's good not to assume, just start from the basis and build up. Thank you.
Okay, I think we are coming to the end of our session today. I think if I've missed any questions in the chat or any raised hands, please let me know. But I would thank everyone for their attendance, and we would very much appreciate if you could complete the evaluation form that I dropped into a link in the chat. That will help all of our presenters in the Ghana College tailor future presentations on this topic to everyone's needs. So thank you again, and have a good evening, and much appreciation to our team here.
Thank you very much, Professor Hobson.